Hello, everyone. We're going to be talking about oxygenation. Oxygenation. So I want you to take a look at the pictures that you have before you of good oxygenation, a healthy lung and function, how gas exchange is able to occur, and oxygen is able to perfuse the organs versus a pneumonia, right? The example of pneumonia where the alveoli is clogged and gas exchange is not able to occur, and therefore there is poor oxygenation, poor perfusion. Pay attention to the objectives in the beginning of your chapter where it says describe the structure and function of the cardiopulmonary system. So you should know the flow of blood through the heart. It's asking you to explain the interrelationship among ventilation, perfusion, and exchange of respiratory gases. And these are some of the things that we'll talk about. And it also says explain the interrelationship among cardiac output, myocardial blood flow, and systemic circulation. And I just want to tell you just right now, it's all about cardiac output. Okay? Cardiac output is it. So if you would think of some things that would cause you to have decreased cardiac output, whether that's a low blood pressure, right? Low blood pressure, decreased cardiac output, right? High heart rate, SVT, decreased cardiac output, prolonged immobility. So our patients that's undergoing surgery with all of these medications that's slowing everything down and dropping the blood pressure, well, guess what? Decreased cardiac output. And anytime you have decreased cardiac output, you're going to have decreased oxygenation and poor perfusion. So remember that. You're collecting your cues will be finding out what is causing, is this a decreased cardiac output question? And if it is, what am I going to do? How can I fix the problem? Is it a clogged artery? Is it a fluid volume deficit problem? Is it a fluid volume overload problem? What is causing this decreased cardiac output? Is it a mobility problem? How can I get my patients up and moving? Do I got to put on some sequential devices to get circulation going to improve cardiac output? So I want you to please take a look, and that was the third dot in your objective. But if you answer these objectives, okay, and if you have to write things down, literally write the answers to these objectives as you're going through. Pay attention to your key terms, okay, angina pectoris, afterload. Really understand what is afterload. What is a BiPAP machine? Okay, we all should know what CPR. What is CPAP? And then start saying, what's CPAP in comparison to BiPAP? So all of these key terms can come up in these questions, but I don't want you to be confused. So please take a look at all of your key terms. Pursed lip breathing is one of them. All right. So let's begin. Let's talk about the work of breathing. So in order to see if your patient has an increased work of breathing, because there should be even rise and fall, right, of the chest, if they are using their accessory muscles, so their intercostal muscles, you can say that they have an increased work of breathing. Or they may be short of breath, not able to talk. So they're talking in one word sentences, right? If that is even a sentence. They're basically saying yes, no, so they're very short of breath. You will see that the depth of their respirations is a little bit deeper. So they're breathing deeper. So they have an increased work of breathing. Okay. So we also want to look at lung volumes. And when you look at lung volumes, the normal lung volumes are determined by age, gender, and height. Okay. So the tidal volume is the amount of air exhaled following a normal inspiration. That's called the tidal volume. Then you're going to have some of the residuals. That's the air that's left in the alveoli after they fully do expiration. All right. So that's kind of like what they're talking about when they're talking about the volume. Okay. So forced vital capacity is the maximum amount of air that can be removed from the lungs during forced expiration. Okay, so the variations in tidal volume and other lung volumes are associated with alterations in patients' health status or activity, such as pregnancy, exercise, obesity, or obstructive and restrictive conditions of the lungs. Okay? So anything that is going to restrict the lungs or clog the lungs, um, they're going to have decreased lung volume. And then what is pulmonary circulation? Sorry. Pulmonary circulation is the primary function of pulmonary circulation is to move blood to and from the alveoli capillary membrane for gas exchange. So that's pretty much what it is. And there is a patho behind that. But basically, that's what it is. We want to move the oxygen-rich blood. We want it to circulate through the pulmonary venules and pulmonary veins to return to the left atrium. Okay, so we kind of talked over it in class, superior, inferior vena cava into the right side of the heart. So into the right atrium, into the right ventricle, into the pulmonary artery, returning to the left side of the heart, to the left atrium, into the left ventricle, and out through the aorta. Of course, we do want you to put your valves in there to know it just like that. So respiratory gas exchange occurs in the alveoli of the lungs, as you can see in the picture here. And remember that this alveolar capillary membrane, there is a capillary membrane there, and depending on how thick it is, the thicker it is, the less the diffusion. Okay, so the thickness of the membrane affects the rate of diffusion. So increased thickness of the membrane will impede diffusion. And what is diffusion? The process for exchange of respiratory gases in the alveoli. So if it's so thick, it's going to take longer for the gases to cross the membrane. These are your patients with pulmonary edema, pulmonary infiltrates, also known as pneumonia, and pulmonary effusion. Okay, so talking about oxygen transport, we know that it depends on three things. All right, you got to basically look at your hemoglobin is number one. How much hemoglobin, the amount of hemoglobin you have, HbG, right? I'll just put 7 in your head, all right? It's different for men and women, but anything less than 7 is going to be cause for your patient to need a blood transfusion because we need more hemoglobin so that it can carry this oxygen. So you got to look at three things: how much hemoglobin you have, you got to look at how much oxygen is in the plasma, and you got to look at the ability of hemoglobin to bind with the oxygen. So those three things, all right? All right. Also, if a patient has blood loss, they're going to have low hemoglobin. So we got to replace that blood, transfuse the patient so that they'll have more hemoglobin to carry the oxygen and perfuse and deliver oxygen to the tissue, which is perfusion. Carbon dioxide is a product of cellular metabolism, diffuses into red blood cells, and is rapidly hydrated into carbonic acid. We talked about that a little bit. It is eventually returned back to the lungs and exhaled. So, what regulates ventilation? CO2. I learned CO2. Chemical regulation maintains the appropriate rate and depth of respiration based on changes in the carbon dioxide, oxygen, and hydrogen ion. Okay? But I always say that CO2 is really the leading force. Now, you do have neuroregulation, which includes the CNS control of respiratory rate, depth, and rhythm. And it's located in the cerebral cortex. The cerebral cortex is what regulates the voluntary control of respirations by delivering impulses to the respiratory motor neurons by the way of the spinal cord, which is why sometimes we can increase our rate and depth of breathing without thinking about it, right? This is controlled by the CNS. The cardiovascular physiology, the structure and function. So here's your heart. Notice that the right side of the heart is blue. So the superior vena cava and the inferior vena cava. This is the right side of the heart. It's blue because it's carrying deoxygenated blood. It's going to return via the superior inferior vena cava into the right atrium into the right ventricle. Is going to be pumped through the pulmonary artery into the lungs. This is where it's going to be oxygenated in the lungs. The oxygenated rich blood is then going to return to the left atrium. Okay, so the left side of the heart is red because now we have oxygenated blood. It's going to go to the right ventricle and then out through the aorta into the systemic circulation. Now we have oxygenated blood going to perfuse the body and the tissues and the other organs with nutrients and oxygen. Now, the myocardium, the heart it has coronary arteries that will supply blood and oxygen and nutrients to itself. Okay, hence when one of these coronary arteries are clogged, we call this a myocardial infarction. And then when you get in your 12-lead EKG, you'll be able to figure out where the infarction is happening. So right now you just need to know that it is feeding itself, the coronary artery circulation. So blood flow regulation, it's all about cardiac output, like I said in the beginning. The amount of blood ejected from the left ventricle each minute is the cardiac output. The normal cardiac output is 4 to 8 liters per minute in a healthy adult at rest. Okay? So the circulating volume of blood changes according to the oxygen and metabolic needs of the body. So when you're sick, you need more, hence why your heart beats faster when you're sick and when you have fever. All right, so if cardiac output increases during exercise, pregnancy, and fever, but decreases during sleep. Why? Because we don't need as much cardiac output as sleep. We don't need as much blood flow. But when we're exercising, we do. When we're sick, we do. When we have a baby in our bodies, we do. Because the metabolic demand is higher, if that makes sense. So cardiac output is equal to stroke volume times the heart rate. Okay? So what is stroke volume? Stroke volume, so I already told you what cardiac output is. The amount of blood ejected from the left ventricle each minute is cardiac output. Stroke volume is the amount of blood ejected from the ventricle with each contraction. That's how much you get out. And we all know what the heart rate is. So the normal range of a healthy adult is 50 to 75 milliliters per contraction. That's how much stroke volume we should have. So what is preload? Preload is the amount of blood left in the left ventricle at the end of diastole. Okay, so before the next contraction, that's how much is left. It is often referred to as end diastolic volume. Okay, afterload is the resistance of the ejection of blood from the left ventricle. So that's how much resistance we have. Okay, and the conduction system, we talked about it already. It's all about the SA node, you all. That's where it starts. So the rhythmic relaxation and contraction of the atria and ventricles depend on continuous organized transmission of electrical impulses. The cardiac conduction system generates and transmits these impulses. All right. So they say that the SA node is where these impulses begin. If it begins in the SA node, we call this sinus, right? Sinus rhythm. So sympathetic and parasympathetic nerve fibers innervate all parts of the atria, ventricle, and the sinoatrial and atrioventricular nodes. All right. So the SA node, think of it as the pacemaker of the heart. It's where it starts. It's where the impulse starts. It is located in the right atrium next to the entrance of the superior vena cava. All right. So impulses are initiated at the SA node, and the rate is between 60 and 100 cardiac action potentials per minute. All right. Hence, same as our heart rate. So you will know that if the rate is between 60 and 100, we can say that it is originating at the SA node. All right. So the electrical impulses are transmitted through the atria along interracial and internodal pathways. So it goes from the SA node to the AV node. Okay. On your ECG, you will be able to see these. All right. From the SA node to the AV node to the bundle of His, and then to the ventricular Purkinje fibers. So a normal sinus rhythm is necessary to ensure optimal perfusion of the tissues in the body. So we want it to be the impulse to be coming from the SA node. So let's talk about the EKG or ECG, electrocardiogram. It is a measurement of the electrical activity of the conduction system. So it monitors the regularity and path of the electrical impulse. So it's going to tell you, the ECG is going to tell you where the impulse began. So again, normal sinus rhythm is implying that the impulse originated at the SA node. The P wave is representing the atrial depolarization. Okay, so atrial contraction will follow the P wave. The PR interval represents the impulse travel time, how long it takes to get from the SA node to the AV node. That's your PR interval, and then through the bundle of His and to the Purkinje fibers. Okay, so the PR interval represents the impulse travel time from the SA node through the AV node, through the bundle of His, and to the Purkinje fibers. The normal length for the PR interval is 0.12 to 0.2 seconds. An increase in the time greater than 0.2 seconds indicates a block in the impulse transmission through the AV node. A decrease less than 0.12 indicates the initiation of the electrical impulse from a source other than the SA node. So if it took a shorter time, we'll say that it did not start at the SA node. If it takes a longer time, we'll say that there's some type of block. So this is just the beginning. I'm not going to quiz you on ECG, okay, electrocardiogram, but just to be introduced to it, I may ask you some of these questions about the PR interval. What does the P wave represent? What's going on during the P wave? So the QT interval represents the time needed for the ventricles to depolarize and repolarize, okay? And a normal QT interval is 0.12 to 0.42 seconds. Okay, so at least know that. Know that a change in electrolyte values such as hypocalcemia or hypomagnesemia, right, or other medications, these things can increase the QT interval. An increase in QT interval increases the person's risk of lethal dysrhythmias. So just do know that. Know that our electrolyte imbalances will affect our QT interval, which is our ventricular depolarization and repolarization, which is lethal. Okay? Next slide. Okay, there are some factors that will affect oxygenation. One is physiological factors. So decreased oxygen carrying capacity. How can we have decreased oxygen carrying capacity? We can be anemic, right? We can breathe in or inhale toxic substances. If we inhale toxic substances and they bind to our hemoglobin will not be able to bind to oxygen. Okay, so we can have anemia. We can have carbon monoxide toxicity. I believe I talked about that. Carbon monoxide is something that has killed many people over the years. So carbon monoxide toxicity, hemoglobin strongly binds with the carbon monoxide, right? Created a functional anemia. And because of its strength to bond, carbon monoxide does not easily dissociate from hemoglobin. So this is your people who go into their cars and they turn it on and they're in the garage and they close the garage and they commit suicide. They die by carbon monoxide poisoning. Carbon monoxide can happen in our homes too. And the signs and symptoms of carbon monoxide poisoning is headache, dizziness, nausea, vomiting, and dyspnea. Okay, so anything that will decrease our oxygen carrying capacity will physiologically affect our oxygenation. It would decrease our oxygenation. Hypovolemia, fluid volume deficit is coming back to you. That's another word for hypovolemia. So know what your patients with hypovolemia is going to look like. They're going to be tachycardic. Their heart rate is going to be fast. Hypovolemia. They don't have enough. So everything is moving, got to move faster, got to move faster. Heart got to beat faster, right? To try to carry this oxygen because we don't have enough. So then you want to think of ways in which we can become we can be hypovolemic, right? So we may not be drinking enough water, right? Or we may have trauma, okay? Or we may have vasoconstriction from medication. We could be severely dehydrated, okay? So these will definitely affect our oxygenation. Decrease inspired oxygen concentration. With the decline of the concentration of inspired oxygen, whether it's because we are at a high altitude, so you do know that the higher you go, the less oxygen there is. So decrease environmental oxygen at higher altitudes. There's a lot of people who are not used to being at higher altitudes. If you already have heart issues like an enlarged heart, you can really find yourself in a very, very dangerous state if you go several feet above sea level. So remember that. And also hypoventilation, which can occur through opioids, right? So anything that will decrease our inspired oxygen. If we're breathing slower because of opioid use, then we're not going to get enough oxygen in, and we're not going to oxygenate or perfuse our organs. If we're at a higher altitude where there's decreased inspired oxygen there's decreased oxygen, so we're not going to be able to breathe in enough or as much as we're used to. And then if we have an increased metabolic rate, all right, pregnancy, we talked about it earlier, exercise, sickness, all right, our body metabolic rate has increased. Then we're going to need more oxygen. So this is our obese patient will need more oxygen. Our patients with pulmonary disease are at greater risk for hypoxemia. And so they talked about obesity. We talk about trauma. We talked about. I also want to talk about the central nervous system alterations. So diseases are trauma of the medulla oblongata, right? And or diseases are trauma of the spinal cord could result in impaired ventilation. So when the medulla oblongata is affected, neuroregulation of ventilation is impaired. So you have an abnormal breathing pattern. Okay? So any type of cervical trauma at C3 to C5 will usually result in paralysis of the phrenic nerve. Very important to note. When the phrenic nerve is damaged, the diaphragm does not descend properly, thus reducing inspiratory lung volumes and causing hypoxemia. If you have trauma below C5 vertebra, it usually leaves the phrenic nerve intact but damages the nerves that innervate the intercostal muscles, preventing anterior posterior chest expansion. Okay. So, lung diseases, you'll see people with COPD have a barrel chest, right? They'll use accessory muscles. Chronic lung diseases can cause dyspnea, tachypnea, hypoxemia, and hypercapnia. And you need to know what all of those mean. Okay? So look it up. Look up all of those. Cystic fibrosis. All of these will influence oxygenation. These are physiological factors that will influence oxygenation. Hypoventilation, we know what that is. That's breathing low. We know that if you're breathing slower, you're going to retain carbon dioxide. Your body is going to become acidic. right? And we all know how the body will try to get into homeostasis if you're hypoventilating. If you're hyperventilating, same thing. Now you're blowing off too much CO2, you're becoming alkaline. And we all know how the body will respond to that as well. So know what hypoxia is. Hypoxia is inadequate tissue oxygenation at the cellular level. It results from a deficiency in oxygen delivery or oxygen use at the cellular level. Hypoxia. Next slide. Well, these we talked about all of these on the previous slide. I think I got ahead of myself, but I think I mentioned all of these. These are the conditions that affect the chest wall movement, which will affect oxygenation physiologically. Pregnancy, I talked about obesity, musculoskeletal abnormalities, trauma, neuromuscular diseases, okay, and central nervous alterations, as well as influences of chronic lung disease. So I believe I hit all of those on the previous slide. Next slide. Hypoventilation. We talked about these alterations on the previous slide as well, but let's just talk about it a little bit deeper. Remember, hypoventilation occurs when the alveolar ventilation is inadequate to meet the oxygen demand of the body or to eliminate sufficient carbon dioxide. So we have a buildup of carbon dioxide in hyperventilation. This can be the cause of, this can be atelectasis, a collapse alveoli is going to cause us not to be able to exchange that oxygen, right? Are those gases? This could also be our patient with COPD. And one thing to remember with the patient with COPD, if they're hypoventilating, they're kind of holding on to that carbon dioxide, it's okay. Their body have gotten it has adapted to that high carbon dioxide level. And so you don't want to stop their work of breathing by giving them too much oxygen. Okay, if you really don't quite understand that, you can look at page 984 of your book under hypoventilation. And it talks about the COPD patient that comes up on a lot of quiz questions. Hyperventilation, this can happen with severe anxiety, infection, drugs, or acid-base imbalances, all right? The body will hyperventilate, try to blow off the CO2. If they're trying to blow off CO2, that means they're trying to blow off acid, which means the body is alkaline, right? Too alkaline, metabolic alkalosis. Okay, so remember those things and definitely know what hypoxia is. It is inadequate tissue oxygenation at the cellular level. That's what we're talking about. All right, so it is a deficiency in oxygen delivery or oxygen use at the cellular level. All right, so what causes that? Decreased hemoglobin, diminished concentration of inspired oxygen. This happens at high altitudes. Diminished concentration of inspired oxygen happens at high altitudes. The inability of tissues to extract oxygen from the blood, as in cyanide poisoning. It also happens when decreased diffusion of oxygen from the alveoli to the blood. This happens in pneumonia or pulmonary edema. Poor tissue perfusion with oxygenated blood, as with shock, right? Because now we got lactic acid buildup. Impaired ventilation, as with multiple rib fractures or chest trauma. So that paragraph there on page 985 under hypoxia, these are all the reasons. These are the cues. These are what we'll be telling you. So look up what the patient would look like if they had these conditions and what you would do. What do you do for the patient with pneumonia, for pulmonary edema? That's how you study for these questions that's coming to you from oxygenation. Next slide. Alterations in cardiac functioning. So we do know that there can be alterations in cardiac functioning, right? So illnesses and conditions affecting cardiac rhythm, strength of contraction, blood flow through the heart to the heart muscle, and decreased peripheral circulation alter cardiac function. So older people, older adults, they have structural changes of their heart. They have vascular involved stiffening increased left ventricle wall thickening, and changes in the conduction system, right? They can have backflow and all of these other chronic diseases that the elderly have. So in altered cardiac output, we can look at left-sided heart failure and right-sided heart failure, and you need to know the difference. So let's remember that in the left sided heart failure, the left side of the heart is where the blood is pumping through the aorta, right? So if we have left sided heart failure, where has the blood come from? The blood was trying to return to the left side of the heart via the pulmonary vein, right? So it was coming from the lungs. It was coming from the lungs. So if it can't get into the left side of the heart because the left side of the heart has failed, then it's going to then back up into the lungs. And now we're going to have crackles, pulmonary edema, right? We're going to have shortness of breath. Versus right-sided heart failure, the blood was coming via superior inferior vena cava, right? So it was coming from the lower extremities and from the superior vena cava. It was trying to return the deoxygenated blood to the right side of the heart. But if the right side of the heart has failed, it is not going to be, it's just going to be a buildup and it's going to back up. And there you have your biliary lower extremity edema. There you have your distended jugular vein, right-sided heart failure versus left-sided heart failure. There you have it. Now, impaired valvular function. So valvular heart disease is an acquired or congenital disorder of a cardiac valve that causes either hardening, and we call that stenosis, 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 or impaired closure, regurgitation of the valves. So that means we're going to have a decrease in cardiac output if it's not going forward, it's going backwards because the valves are not working. They're too stiff or it's regurgitating backwards. So now our oxygenation is going to be decreased. Decreased cardiac output means decreased perfusion. So we're all talking about what causes this decreased cardiac output, right? Myocardial ischemia, MI, heart attack. It results when the supply of blood to the myocardium from the coronary arteries is insufficient to meet myocardial oxygen demands. So this can be ischemia, it can be angina, or it can be a myocardial infarction. Okay? So let's talk about angina. Angina pectoris is a transient imbalance between the myocardial oxygen supply and demand. The condition results in chest pain that is aching, sharp, tingling, or burning, or feels like pressure, is what they'll say. Typically, chest pain is left-sided or substernal and often radiates to the left or both arms, the jaw, neck, and back. But in some patients, it does not radiate at all. Okay? It usually lasts for 3 to 5 minutes. All right? Patients report that this is often precipitated by activities like exercise or eating too heavy, stress, and it is usually relieved when they rest or if they get vasodilators. And the most common vasodilator that we give is nitroglycerin. Okay? So they'll give the nitroglycerin under the tongue, very important. Y'all know your fundamentals, but you need to know this. So the max that we give is 3. So we place the nitroglycerin sublingual under the tongue for this chest pain, this angina pectoris, right? And it's usually relieved. So we put it under there. If it's not relieved, we will give them another one after 1 minute. If it's still not relieved, we'll give them another one. So only 3, right? We only give 3 in 3 minutes. If it's unrelieved, then we are suspecting a myocardial infarction because it is unrelieved pain. But with angina pectoris, it will be relieved. I think I said that right. So then let's really look into this myocardial infarction, or we also call this acute coronary syndrome, ACS. It results from sudden decrease in coronary blood flow or an increase in myocardial oxygen demand without adequate coronary perfusion. All right. So this can be your patient with an enlarged heart that went to the mountains, that went up to Big Bear, and where there was less oxygen, and now the demand is higher. The demand that they needed and that they were used to here in Long Beach, now they are at a higher altitude and is not able to meet the demand of the heart because there's less oxygen up there, right? So now, chest pain associated with MI in men is usually described as crushing, squeezing, or stabbing. The pain is often in the left chest and sternal area, may be felt in the back, and it radiates down the left arm to the neck, jaw, teeth, epigastric area, and back. It occurs at rest, not when exercising, at rest or exertion and lasts more than 20 minutes. So notice angina pectoris only lasted 3 to 5 minutes. Now with the myocardial infarction, it is lasting 20 minutes. Rest, position change, sublingual nitroglycerin administration, nothing helps. Nothing relieves the pain. So as you can see, there's a difference between myocardial infarction and angina pectoris, okay? All right, so know that because it's coming for you on the test. Next slide. Okay, so factors influencing oxygenation, developmental factors. So for infants and toddlers, they have higher rates of infection from ages 3 to 6 months, okay? Um, so they're at risk of upper respiratory tract infections, especially when they're exposed to secondhand smoke. All right, and also they like to put things in their mouth, so their airway can be occluded by foreign objects. For school-aged children, they start smoking, right? So yeah, secondhand smoking, but once they get to adolescence, they usually some begin smoking. 4.5% of middle school age children and 16.5% of high school children said that they use tobacco. And this is including electronic cigarettes being the most common one because it tastes good, right? They have different flavors and things like that. These adolescent children and school-age children are also at risk for coronary pulmonary disease because of obesity, McDonald's, Jack in the Box, Taco Bell, and all the other places that my kids like to go to, right? It's unhealthy diets and excessive use of caffeinated beverages because they get a big size soda with all of that stuff. We gotta do better. And please, hopefully, they're not drinking energy drinks. But outside of our sites parents, if you have a young adult, adolescent, they probably are. When you're talking about young adults and middle adults, this is the majority of you in here. Um, they are at risk because of unhealthy diets as well, lack of exercise, stress from school, over-the-counter and prescription drugs, illegal substances, smoking, and just not making good choices about their health care. They feel like they're going to live forever, so they don't go to their physicals. Um, the increased cost of cigarettes plus the state's smoke-free air policies laws have proven to be helpful in smoking cessation. So that's one of the things that was brought about by your book. And then in older adults, the cardiac and respiratory systems undergo changes that we talked about already, right? So you have vascular stiffening, like I said before, the left ventricle wall will thicken, impaired SA node function, and all of the other arteriosclerotic plaques that occur. Okay, so what is that atherosclerotic plaques? That's the buildup that clogs their arteries. So it increases. Next slide. So habits are hard to change. One of the biggest things that we see in our patients that are obese is that they are at risk for hypertension. Okay, so hypertension is in the United States is one of the leading cause of death. And so I'm going to focus on that just a little bit here and tell you that it's very important to teach our patients with hypertension, how to control it. Okay. Um, we want to teach them how to eat. We want their diet to, first of all, they need more calories, but they need smaller meals. Okay, because of their increased work of breathing. We don't want them to over indulge because it will make the work of breathing even of more demand. So obesity affects the respiratory and cardiovascular system. It leads to decrease in lung expansion and an increase in oxygen demand to meet the metabolic demands, right? So what do we tell them to eat? Fruits, vegetables, low-fat dairy foods, foods that are high in fiber and potassium, calcium, magnesium, and we want it low and saturated in total fats, okay? This will help them in their risk for a myocardial infarction. Hydration, we know that people with heart disease and kidney disease are at risk for fluid volume overload, and dehydration or fluid volume deficit may result in dizziness because we sometimes they're on fluid restrictions, right? So now they are at risk for fluid volume deficit, which will be manifested by what? Hypotension, fluid volume deficit, hypotension, dizziness, the brain is not being perfused, right? Fainting or a thickening of respiratory secretions. And this makes it a bit harder for the patient to get this, we call it expectorate the secretions. Okay? So these are all the things and lifestyle factors that can cause deoxygenation or poor perfusion. Exercise is very important for us to encourage our patients to exercise. We want them to exercise for 30 to 60 minutes daily. Okay? Because evidence-based, this is going to lower their pulse rate and it will lower their blood pressure and it will decrease their cholesterol level and it will increase their blood flow. Next slide. So please know that environmental factors also play a part. A patient's environment. So rural populations have more COPD related issues that are not directly related to the environment, but rather the fact that more people there are smoking and they have an increased exposure to secondhand smoke. All right, less access to smoking cessation programs and higher likelihood of rural residents being uninsured. So environmental factors matter. All right. Also, people who work have occupational pollutants, okay, including asbestos, talcum powder, dust, and airborne fibers. They are all at a greater risk for having oxygenation perfusion issues. So now, on to the critical thinking. Just know that knowledge of cardiac and respiratory physiology and oxygen supply and demand provides a scientific basis for how you approach an assessment of your patient. Critical thinking attitudes ensure that you approach patient care in a methodical and logical way, and the use of professional standards provides valuable guidance in the care and management of the patient. Okay, so there are standards. There is something that you are supposed to do if you see that your patient is having decreased oxygenation or perfusion. The number one sign is anxiety. Anxiety, right? Next slide. So when you get to API and you start talking about your assessment, you want to assess for health risk, right? You want to assess for whether or not they have a history of smoking. So you want to know what their occupation is, all right? This is all a part of your health assessment. You want to see if they are in pain. So the presence of pain, chest pain, could be it can be um, leading to a myocardial infarction, right? So you want to make sure you include the location, the duration, the radiation, and frequency of this pain. All right. Um, Also, you want to talk about fatigue. One of the signs that a patient has sleep apnea, this also came up in your book, is that they would have fatigueness and weakness, and they would have a headache upon wakening. So you want to assess for those things, okay? Dyspnea is associated with hypoxia. So if they have to sit up on pillows, this is a sign that they're having increased work of breathing. All right. So they're dyspneic at rest. So ask the patient when the dyspnea occurs, such as does it occur when you're exercising, or if you does it occur when you're at rest? And then you want to ask what improves the dyspnea. Is it rest, inhaled medications, or position change? So you want to talk about how they feel when they're lying flat. Orthopnea is an abnormal condition in which the patient uses multiple pillows when reclining to breathe easier or sits leaning forward with arms elevated. Okay, so that means they're having trouble breathing. One of the first signs that a child or anyone with asthma is having an exacerbation is they will have a cough, right? So coughing is a protective reflex to clear the trachea, bronchi, and lungs of irritants and secretions. So if they're coughing, and it's a dry cough, it's usually some type of airway tightening, right, or restriction. We see that a lot in asthma. We want to ask, what do they do to make it better? You know, is it the medication, the inhalants, or what is it that makes it better? What makes it worse? Is it exercise, right? If they're having hemoptysis, this is bloody sputum. We want to know. We can use pH paper, by the way, to say where the source is coming from. But we want to make sure we describe what it looks like, the amount, the color. Was it mixed with sputum, green sputum, yellow sputum? What was going on? Okay, and sometimes they may do chest X-rays and bronchoscopy. Okay, that's where they will scan the bronchioles. All right, next slide. So including your assessment, environmental and occupational factors. So I do want you to know that as far as environmental factors, um, if they live by a freeway, if they have a house full of dust, if they have mold, cockroaches, pet dander, asbestos, these are all linked to respiratory diseases. And a lot of people can have these things. And I know sometimes you move in a house or a property and they'll just paint the walls over the mold. And you're like, oh, why do I keep getting sick? You know, so there's patients like that they just kept getting sick, didn't know why they was getting sick, but it was because they moved into a house that was covered in mold and just painted it. They just painted over it. So you got to be very, very careful with the environment. So do a good assessment. Cockroaches do have they have been known to also cause respiratory diseases. So you also want to teach about carbon monoxide poisoning. It's often it comes from an improperly vented furnace or fireplace. What else do I want to say about? We talked about carbon monoxide already. So we should all have a carbon monoxide detector in our home. I would say that. Okay. And smoking, we got to remember that secondhand smoke kills, and we want to teach smoking cessation. All right, respiratory infections. When thinking about respiratory infections, we want to ask how many times are they getting the flu? Do they get the flu every year? Do they get pneumonia every year? You know, do they have a history of TB? So these are the things that we want to ask about. Patients can be at risk for HIV infection. So patients with a history of IV drug use, they usually have a higher probability of contracting HIV. We want you to know that patients don't always have the symptoms of HIV. Okay, so patients with HIV are immunocompromised, and it puts them at risk. One of the things would be that they keep getting frequent respiratory infections. That's one of the signs. COVID-19 is another one that came up in your book. Okay, so people of any age can get this virus, so let's continue to wash our hands and be vigilant. And if we're sick, stay home. Allergies, you want to know about your patient's exposure to allergens. Are they allergic to pet dander, pollen, or mold? And if they are, we want to teach them on how to clean their homes of these things and tell them the signs and symptoms, okay? Runny nose, watery eyes, sneezing, respiratory symptoms such as coughing or wheezing. This could all be allergies, right? Medications. Um, so we want to know what our patients are taking, whether it's herbal medicines or over-the-counter medicines or prescribed medicines. Okay, so patients taking warfarin for blood thinning, prolong the prothrombin time, PT, interval, normalizing ratio, NR, results if they are taking ginkgo biloba, garlic, or ginseng with an anticoagulant. Okay? I know I said that kind of broken up, but I really want you to pay attention. When you're looking at your PT and INR, this is on the lab paper that you guys hate, right? These are your coagulation tests, right? So this is telling us how thick or how thin the blood is. This is very important because it needs to be in a certain range. So if your patient is taking ginkgo biloba, I have a mother who takes a clove of garlic every day. They're taking ginseng. This can be life-threatening if taken alongside an anticoagulant. Okay? So the drug interaction can precipitate life-threatening bleeding, such as gastrointestinal bleeding. So you want to assess what medications your patients are on. Okay? And we know about opioids. Okay. Next slide. So you want to do your physical examination in your assessment. You want to look at inspect, you want to palpate, right? What are you looking for? What in your inspection can you see? All right. So on table 41.2, it talks about some things that you can see. You can see pale conjunctivae, cyanotic conjunctivae. These are signs of anemia and hypoxemia. So go through because these will be your collecting the cues, table 41.2. Okay. It goes all mouth and lips. You can have cyanotic mucous membranes, pursed lip breathing. This is associated with chronic lung disease. You can have retractions. You can have asymmetry, the chest wall moving unevenly, right? So cyanosis comes up a lot. The skin, right? Decreased skin turgor. You can have dependent edema. So this is things that you'll do during your assessment phase, right? It's just inspecting the skin and the patient, right? You can see what position they're sitting in. So palpation of the chest wall provides assessment data in several areas. You can palpate edema, right? And when you palpate edema, edema is graded from 1 to 4, depending on the depth of visible indentation after firm finger pressure. All right. So I believe they have really good videos for you to see. But if they have, we use a scale of 0 to 4, right? When we're talking about our pulse. So you can look at your pulses and also palpate the pulse to see the fluid volume status. If it is 0, then your pulse is absent. And it goes all the way to 4 plus, which would be bounding, which would be seen in fluid volume overload. And then a normal would be 2 plus, and then weak and thready would be seen in fluid volume deficit, right? And this would be like a 1 plus. Why am I talking about the how we scale our pulse? Because if you have a weak and thready pulse, you need to tie it to fluid volume deficit, which you then need to tie to oxygenation. Because if you have fluid volume deficit, you're going to have decreased output, you're going to have decreased perfusion. So that weak and thready pulse is going to let you know. So I may not on the question tell you that you're fluid volume deficit, but I will tell you that you have a weak and thready pulse, right? So those are the ways that you bring it in, right? Bring in those cues. Auscultation, you can auscultate the lung sounds, right? And if you hear wheezing, crackles, or ronky, this will let you know what's going on in the lungs. All right, diagnostic tests. It's a variety of diagnostic tests are used to monitor and assess coronary pulmonary function. Some are non-invasive. We have pulmonary function studies. So there are various tests. Now, when you get into the blood studies, this is very important. You have your complete blood count, your CBC, and it tells you exactly what it means. So you need to study this page. This is table 41.3. The CBC determines the number and type of red and white blood cells per cubic millimeter of blood. White blood cells assess for presence of infection. Red blood cells and hemoglobin assess for presence of anemia and the ability of the blood to carry the oxygen. So we need to study our labs again. And here they are. I like the way your book lays it out on table 41.3. They talk about the cardiac enzymes, okay? Your CK. Sorry. They talk about your troponins. Plasma cardiac troponin 1 should be less than 0.03. Plasma cardiac troponin T should be less than 0.1. This value often remains elevated for 10 to 14 days during a STI injury, myocardial injury. Okay? And then they have your electrolytes, potassium on there. They have cholesterol here. So these are more that we're adding to what we already had. Know about your cardiac function diagnostic test, your Holter monitor. This is a portable ECG that our patients usually go home with this, and we get to monitor their ECG readings while they're at home. Okay, so we look at the electrical activity of the heart during activities of daily living. All right, they talk about the stress tests. All right, so go through these tables. This was table 41.4. And then 41.5 talk about your arterial blood gases. So it talks about your pH of 7.35 to 7.45. It talks about your PCO2 of 35 to 45. Okay, your PO2 of 80 to 100. So all of that is on here. It talks about your peak expiratory flow rate. This is the point of highest flow during maximal expiration. Normal in adults is based on age and body. It reflects changes in large airway sizes and an excellent predictor of overall airway resistance in a patient with asthma. All right, so that's your peak expiratory flow rate. They talk about the bronchoscopy, the lung scan, the thoracentesis. This thoracentesis is a surgical perforation of chest wall and pleural space with a needle to aspirate fluid for diagnostic or therapeutic purposes. So sometimes, especially patients with liver cirrhosis, they can end up with fluid in the abdominal. So they would do a paracentesis. Sorry, we're talking about thoracentesis. Never mind. Scratch that. But this one is the thoracentesis is for the lung, the pleural space in the lung. Sputum specimens, they talk about that. So this is a very good table, 41.5. All right, it talks all about your diagnostic studies. Okie dokie. Next slide. Just talking about your diagnosis part of EPI, you can have impaired cardiac output. And again, impaired cardiac output is what counts. That's what we're looking at. Anything that's going to decrease cardiac output, your opioids, your immobility, your CHF, your left side or right foot, whatever is going to decrease pneumonia, cardiac output is going to decrease perfusion. So acute pain, activity intolerance, fatigue, and impaired airway clearance. Next slide. We want to plan for good perfusion, right? We want to plan that our patient is able to breathe if they had an increased work of breathing, now their work of breathing is within normal range for the client, right? For the patient. So setting your outcomes depends on your assessment, okay? If your patient was cyanotic and had shortness of breath, now they do not have shortness of breath, right? If they could not, if they were unable to clear their airway, now they're able to have a productive cough because we gave them some medication that helped them to have a productive cough. So we want to set our priorities always along the ABCs in Maslow. And remember to conduct your team. So RT therapy The respiratory therapist is the one that's going to be your best friend during these times, right? They're going to be the one drawing the blood gases. They're going to be the one doing the physiotherapy. They're going to be the ones doing the breathing treatments and all of that good stuff. Next slide. Talked about this. We want to teach healthy diet. We want to teach get your flu vaccines and your pneumonia vaccines and your COVID vaccines. And we want to talk about our environmental pollutants, how to get rid of dust and mites and cockroaches and just have a clean environment. So these are the things that we want to promote with our patients. We discussed them earlier. Next slide. So again, we want to know how to care for our patient that's dyspneic. The first thing is to sit them up. And if you look at this picture, this they have the it's kind of like a band wrapped around the patient's chest. This would be for physiotherapy, trying to move around those secretions. It's called mobilization of pulmonary secretions. So they have machines now that do it. We want to teach to hydrate. Anytime you have thick secretions, we want them to drink lots and lots and lots of water to thin those secretions out so that they're able to cough it up, right, and get it out of the bronchioles and alveoli. Humidification helps break up those secretions. Nebulization medications are to be inhaled into the lungs, and they help break up the secretions as well. Cough and deep breathing techniques will help get the secretions moving and help expand the lungs. And chest physiotherapy, and that's when they kind of massage the anterior and posterior chest. Next slide. We want the patients up and moving. Get up, let's move, position. We want them sitting up if they cannot breathe. Next slide. If our patient, and this didn't go through it, but it should have. I know your osmosis video does go through the different, we start off with the nasal cannula to the simple mask to the non-rebreather to the high flow oxygen cannula and to intubation. Okay, so that is usually the direction that we go. It depends on our patient. So if we got them on high flow and they're still setting 88, we're going to prepare to intubate. So in intubation, this is an oropharyngeal tube that you see here on this picture. They also have some that are nasopharyngeal that will go through the nose. It just for various reasons. Okay, and we also have a tracheal tube, right? And that will be a little slit in the neck area where we will do a trach. Okay, so these are artificial airways. Next slide. Evaluation is through the patient's eyes. We basically want our patients to have good perfusion and oxygenation. Next slide. I will read our safety guidelines. So you need to know your patient's baseline range of vital signs. You need to know what's normal for your patient, what's their baseline. You need to know their medical history. You need to identify conditions that increase a patient's risk for aspiration of gastric contents into the lungs, resulting in airway obstruction and pneumonia. You need to be able to identify patients at risk for problems due to suctioning, such as trauma to the upper and lower airway, nasal polyps, coagulopathies, recent head and neck surgery, or hemodynamic instability. You also need to know that artificial airways alter the patient's ability to communicate, possibly causing feelings of fear, frustration, anxiety, and vulnerability. The oropharyngeal suctioning with a Yanker catheter tip can be done using a cleaning technique. Nasopharyngeal, nasotracheal, and artificial airway suctioning should be done using aseptic technique. Next slide. You must do the suctioning of the trach and the oral cavity. You want to perform tracheal suctioning before oropharyngeal suctioning whenever possible. If there's an abundance of oral secretions present before beginning the procedure, suction mouth with separate oral suction device. Use caution when suctioning patients with a head injury. Reduce this risk of intracranial pressure by pre-oxygenating the patient before suctioning, which results in hypercapnia. So if you're going to suction a patient, make sure you hyperoxygenate first. That means give them a lot of oxygen, okay? Put on a mask over their face and let's hyperoxygenate them before you suction. I hope that makes sense, because when you suction up oxygen too. So you want to give them more oxygen so it can be covered and you won't cause them to be deoxygenated. And you can increase their intracranial pressure if they have a head injury. The routine use of normal saline into the airway before endotracheal and tracheostomy suctioning is not recommended. Use of normal saline is associated with adverse effects of excessive coughing, bronchospasms, spread of organisms to the lower respiratory tract, and decreased oxygenation saturation. In certain circumstances, if it is necessary to stimulate a cough, normal saline may be indicated. This requires collaboration with the healthcare team, so don't just do that on your own. Next slide. The most serious tracheostomy complication is airway obstruction, which can result in cardiac arrest. Most tracheostomy tubes are designed with a small plastic inner tube cannula that sits inside the larger one. If the airway becomes occluded, the smaller one can be removed and replaced with a temporary spare. It is important to always have a spare at the bedside. Okay? Always review your agency policy before doing anything. But in this case, your book wanted you to know before stripping or milking chest tubes. Review your policy. This concludes our oxygenation lecture. I hope you enjoyed the lecture as much as I did. I'll see you all next time. Have a wonderful, wonderful day or evening, whatever time you're listening to this recording. See you soon.